Welcome back to the second masterclass. I'm Dr. Naveed Zafar, clinical physiotherapist. Last time we tackled two shoulder cases. Today we move to the knee, a joint that new grads think is easy until they're alone with the patient and the history doesn't match the textbook. Same format, two clinical MCQs. I will show you the case, you pause and think, then I will break down every option, why three are wrong and why one is right. But more importantly, I will teach you the concept behind the answer because memorizing answers is not clinical reasoning, understanding is. The knee seems simple, bend, straighten, weight bear, but the knee hides secrets, meniscus or ligaments, acute or chronic, local or referred. Today's cases will test exactly these gray areas. Grab your notebook, pause when I tell you to. Let's begin. But first, a rapid concept revision. The knee has two menisci, medial and lateral. They are shock absorbers. The ligaments, ACL, PCL, MCL, LCL, are stabilizers. Meniscal injuries happen with twisting on a loaded knee. Ligament injuries happen with sudden direction changes or direct impact. Knowing the mechanism is half the diagnosis. Here's your first case. A 55-year-old woman presents with medial knee pain for 4 months. She describes stiffness in the morning that lasts about 15 minutes and then eases. She also reports a catching sensation when she walks, especially on uneven ground. There is no history of trauma. On examination, there is joint line tenderness on the medial side. McMurray's test is positive. Range of motion is full but painful at end range flexion. What is the most likely diagnosis? Option A, knee osteoarthritis. Option B, medial meniscal tear. Option C, pes and serine bursitis. Option D, patellofemoral pain syndrome. Pause the video. This case is tricky because the age and morning stiffness might point you one way, but the examination points another. Write down your answer. Press play when you are ready. Alright, the correct answer is B, medial meniscal tear. If you choose A, osteoarthritis, I understand why. But let me explain the crucial difference. Option A, knee osteoarthritis. This is the trap. The patient is 55, she has morning stiffness. These are classic osteoarthritis features. But here's the detail that changes everything. Osteoarthritis morning stiffness typically lasts less than 30 minutes. Here is 15 minutes that fits, but OA pain is usually diffuse around the whole joint, not pinpoint at the joint line. And OA doesn't typically give you a positive McMurray test with a true catching sensation. Catching means something mechanical is getting stuck, like a torn meniscus flipping in and out. OA gives you crepitus and stiffness, not true mechanical catching. Option C, pes and serine bursitis. The pes and serine is on the medial side. Yes, but it's about 2 finger widths below the joint line. On the tibia, not the joint line itself. Pain from pes and serine bursitis is localized there, and it worsens with activities like climbing stairs, not with twisting or uneven ground. Plus, McMurray's test would not be positive with bursitis. McMurray's tests the meniscus, not the bursa. Option D, patellofemoral pain syndrome. This is anterior knee pain around or behind the kneecap. It hurts with prolonged sitting, stairs, and squatting. It doesn't give you medial joint line tenderness. It doesn't give you a positive McMurray's test. Different location, different provocations. This patient's pain is medial, not anterior. Option B, medial meniscal tear. Now let's understand the basic concept. The meniscus is a C-shaped piece of fibrocartilage. It sits between the femur and tibia, acting as a shock absorber. In a younger athlete, meniscal tears are usually traumatic, a twist on a loaded knee, but in an older adult, over 50, the meniscus can degenerate. It becomes less elastic. Even a simple squat or a walk on uneven ground can cause a tear. This is called a degenerative meniscal tear. McMurray's test, you flex the knee, palpate the joint line, and then rotate the tibia internally or externally, and then keep on extending the knee. A positive test is a palpable or audible click with the pain at the joint line. It's not always dramatic. Sometimes it's subtle, but when positive, it's highly suggestive of a meniscal tear. Our patient had exactly that: joint line tenderness, positive McMurray's, and mechanical catching. Here's the concept that will save you. Degenerative meniscal tears often coexist with early osteoarthritis. The patient might have both, but your job is to ask, what's the dominant problem? If the pain is mechanical, catching, locking, giving way, the meniscus is likely the primary issue. If the pain is dull, diffuse, and stiffness predominant, think osteoarthritis. Don't lump them together, separate them clinically. So, your takeaways: number 1. Morning stiffness under 30 minutes can happen in both osteoarthritis and meniscal tears. Don't let it fool you. Number 2. Catching and locking are mechanical signs. Think meniscus, not just arthritis. Number 3. Joint line tenderness plus positive McMurray's equals meniscal pathology until proven otherwise. And number 4. Always consider degenerative tears in patients over 50, even without trauma. That is your first case, a meniscal tear hiding behind osteoarthritis-like symptoms. This is real clinical physio, separating overlapping presentations. Ready for case 2? This one is about the ligament that is most commonly missed. Case number 2. A 30-year-old motorcyclist presents with knee pain and the swelling after a collision 3 days ago. He says a car hit him from the front while his foot was on the pedal. His knee was bent and his shin hit the dashboard. On examination, there is mild swelling, posterior knee pain, and a positive posterior draw test. Lachman's test is negative. What is the most likely injury? Option A, ACL tear. Option B, PCL tear. Option C, medial meniscal tear. And option D, patellar tendon rupture. Pause. The mechanism here is everything. Dashboard injury, posterior draw positive, Lachman's negative. Write your answer. Correct answer is B, PCL tear, the posterior cruciate ligament, also known as the forgotten ligament. Let me tell you why most new grads miss this. Option A, ACL tear. ACL injuries are common and the knee was bent during impact. That could stress the ACL, but here's the specific clue that rules out ACL. Lachman's test is negative. Lachman's is the most sensitive test for ACL integrity. If it's negative, the ACL is likely intact. And the mechanism, a direct posterior force on the tibia with the knee flexed, like a dashboard hitting on the shin, that pushes the tibia backwards. That stresses the PCL, not the ACL. Option C, medial meniscal tear. Meniscal injuries happen with twisting on a loaded knee. This mechanism is a direct posterior force, no rotation, and McMurray's is not mentioned as positive. The posterior draw test is positive. That's a ligament test, not a meniscal test. Option D, patellar tendon rupture. This causes inability to actively extend the knee. Patella sits higher than normal, also known as patella alta. It happens with a sudden explosive contraction of the quadriceps, not a dashboard impact, and the posterior draw test would not be positive in a tendon rupture. Option B, PCL tear, the posterior cruciate ligament. Now let's understand this ligament. The PCL is the strongest ligament in the knee. It prevents the tibia from moving backwards under the femur. The mechanism for PCL injury is classic, a posteriorly directed force on the proximal tibia with the knee flexed. Dashboard injury, that's why it's called a dashboard injury. The tibia is pushed backwards and the PCL takes the force. The posterior draw test, you flex the knee to 90 degrees. You place your thumbs on the tibial tuberosity and push the tibia backwards. If it moves posteriorly more than the uninjured side, the PCL is likely torn. But here's a mistake new grads make. Sometimes the tibia is already sagging backwards. Because the PCL is torn, you might mistakenly pull it forward and think the ACL is lax. That's a false positive Lachman's. Look at the knee from the side. If the tibia looks like it's sitting back, that's a posterior sag sign. PCL tear, until proven otherwise. PCL tears are missed more often than ACL tears. Why? Because the knee often looks relatively normal. Swelling is usually mild. The patient can walk. It doesn't have the dramatic instability of an ACL tear, but over time, a chronic PCL deficiency leads to patellofemoral pain and medial compartment arthritis because the altered mechanics overload those areas. So, your diagnosis today changes the patient's need 20 years from now. Your takeaways: number 1. Dashboard mechanism plus positive posterior draw equals PCL tear. Number 2. Always check for posterior sag before doing Lachman's. Number 3. PCL tears are subtle but serious. Don't miss them. And number 4. A negative Lachman's rules out ACL, not PCL. They are different ligaments, different tests. 2 knee cases, one meniscus, one PCL. Both are commonly missed by new graduates. Both can change a patient's life if diagnosed correctly. Comment below which one did you get right and what is one clinical pearl that you will use in your next clinical assessment. Subscribe, hit the bell and share this with your physio friends who are preparing for their exams. or starting their clinical practice. I am Dr. Naveed Zafar. Keep learning, keep thinking. See you in the next one.